So I see quite a lot, I see a huge amount of very sick babies with congenital heart disease. So when we're looking at fetal cardiac disease, obviously congenital heart disease is by far and away the largest number, but we have tachyarrhythmias, bradyarrhythmias, cardiomyopathies, and cardiac tumours. I'm not going to mention cardiac tumours, and I'm not going to talk about tachyarrhythmias. Congenital SVTs are very common. They seem to settle, and they're not a major issue as long as you pick them up. You might get them with fetal hydrox, but I'm not going to take that any further. When we look at the bradyarrhythmias, I will come back to a few of those later on, but they can be due to the congenital heart disease with atrial isomerism. We have long QT, we have catecholaminergic polymorphic ventricular tachycardia, or CPVT, and there are these mitochondrial diseases which pop up, again, also with cardiomyopathies, which catch us unawares sometimes. Now, congenital heart disease is a very, very complicated process. To form the heart, remember we've got over 400 genes that are required to shape the heart, and that early looping of the heart requires very, very tight timing of gene expression. So there's a huge amount that has to come together very early on in embryological terms with gene expression to get your heart in the right place. Now I'm going to give you a case presentation which I think is extraordinarily interesting, which is a little kiddie I met at the Royal Brompton. He was prenatally, he'd been identified with a hypoplastic aortic arch and a mitral valve hyperplasia, and all invasive tests were refused prenatally, and postnatally he was also found to have coarctation and ASD and VSD. And he had lots of other non-cardiac abnormalities, and he had short fingers and toes, short long bones, vertebral abnormalities, and agenesis of the corpus callosum. So this will be a typical case for us to get going with our exome sequencing, and this is whole genome sequencing now in the postnatal field. And we found a mutation in this gene called kynurin. Now why am I bothering to tell you about this? Well, the kynurin pathway is a way that you convert tryptophan into NAD. Now, NAD is an absolutely essential component of mitochondrial and endless other genetic or metabolic processes. And it can be rescued, this condition, by giving vitamin B3 or niacin. So we can rescue this disease by giving a vitamin replacement. Now what does that tell us? It tells us how important the diet is and what we are missing. And I think there are many, 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 many other ways that we can possibly supplement our babies to have a reduced risk of recurrence of congenital heart disease. We're not there yet, but this just was an example to me of where we should be going. So we know that there's a considerable recurrence risk with congenital heart disease. So we know there's a genetic background. And we know that same-sex twins, so that suggests potentially that they are identical. We know that unlike twins have a higher recurrence risk. And if you've got a first-degree relative, again, and that can be a parent or a sibling, and it falls off rapidly. So there are, without doubt, multifactorial genetic components to recurrence risk for congenital heart disease. There are certain congenital heart disease that have a very high recurrence risk, and the heterotaxis, well, we know about primary ciliary dyskinesia or PCD, and there are various heterotaxy syndromes where you get a high recurrence risk, and there's quite a lot of autosomal recessive syndromes there, so that's quite understandable. Truncal defects, well, there's DeGeorge syndrome that has quite a high parental carriage rate. There is ABSDs. Those probably have the highest risk. But then we've got the right ventricular outflow tract obstruction, and that probably is put down to the Noonan syndrome, which again has a high, there's quite a lot of parents who are going on to have children. Now, the more we are curing, or not curing, the more we are able to treat effectively congenital heart disease, the more people going on to have children who've had congenital heart disease themselves, the higher the recurrence we're actually seeing. So, what signs of congenital heart disease do we see outside the heart? Well, the nucleotranslucency, well-known association with congenital heart disease. The absent ductus venosus, always look at that ductus venosus, and I think I said earlier, if you've got Noonan syndrome and absent ductus venosus, there is a much, much, much worse prognosis. The cardiac failure in utero is very rarely due to secondary to congenital heart disease. You might get a premature closure of the ductus arteriosus, but I really don't think that's normally a genetic problem, and often it's a sick baby, maybe hypoxic or something like that. Epstein's anomaly is said to be one of the ones that does cause fetal congenital heart problems in utero. And I think that is due to the fact that it's got some underlying single gene disorders associated with Epstein's, which is also associated with cardiomyopathy. So that one might have a slightly different abnormality. So we can identify congenital heart disease in the first trimester, but obviously not all. And what do we miss? Well, we're always going to miss a persistent ductus arteriosus. We should have a persistent ductus arteriosus in utero. We should have an ASD. Total anomalous pulmonary venous drainage we've already heard about, but it's very, very difficult to pick up in utero. Cooptation develops later on in the pregnancy, as does pulmonary stenosis. We see pulmonary stenosis in identical twins. Pulmonary stenosis in Noonan syndrome is not present at 20 weeks in the vast majority of cases. If you think that this is Noonan syndrome, you must do a cardiac scan at 32 weeks. You are not going to pick up the majority of the congenital heart disease early. So what are the chromosome abnormalities? Well, Down syndrome. We all know about Down syndrome and congenital heart disease, ABSDs, the commonest. The family histories are only present with those with balanced Robertsonian translocation. DeGeorge syndrome is the second commonest chromosomal abnormality causing congenital heart disease. It really is pretty common. 10% is said to have a family history. I think that's an overestimate. I don't think a lot of these young women or men who have DeGeorge syndrome go on to have children themselves, but some of them do. 80% have congenital heart disease, interrupted aortic arch. 40% of them have DeGeorge syndrome, 60% are caused by other things. And 5% of isolated aberrant right subclavian artery is associated with DeGeorge. So we offer an amniocentesis with anyone with an ARSA. So the overall incidence, though, of ARSA is at about 0.9% of the population, and it is not increased in Down syndrome, but as I said, there's possibly a 5% risk, even if it's isolated, of the baby having DeGeorge syndrome, so invasive testing. So, when we're looking at chromosome abnormalities, we've obviously got the major trisomies and monosomy X or Turner syndrome. We've got mosaic abnormalities, chromosome abnormalities such as trisomy 8 and trisomy 9. And then we've got the small deletions, including 22q. We've got Wolff-Hirschhorn syndrome. We've got Cri-du-Chat, and then the other ones, there's Williams syndrome. You're not going to pick up Williams syndrome normally, that's supravalvular aortic stenosis, and I think we've only picked that up about once antenatally, and we found it, but I'm not sure that we actually found the reason why. And 1p36, again, can have total anomaly pulmonary venous drainage, very severe intellectual disability. So any congenital heart disease, we offer an invasive testing with a full array. So, if it's got multiple congenital abnormalities, and then you've got, we know that it's highly likely that there is a syndromic diagnosis. Many are de novo, and there are some autosomal recessive disorders. So what are the most common ones we see? Well, not probably, I know there is the CHD syndrome, CDH7, Kabuki syndrome with KD2MD, KMD2D, isomerism, I mentioned PCD, Wilson syndrome with ZB2, and Rubinstein-Taby. All of these will probably have other congenital heart disease, so a full, as soon as you found congenital heart disease, you need to look for specific other abnormalities. Broad fingers and toes is a really good sign in Rubinstein-Taby, but it's jolly difficult looking at broad thumbs. I mean, I really, really admire you if you can actually find those. But CHD syndrome, which is along with Kabuki, Kabuki you often have co-optation, and co-optation is more and more associated with other congenital heart disease. And if you have congenital heart disease, the prognosis for that congenital heart disease is much worse if you've got one of these syndromes. They do worse from the heart point of view, let alone anything else. So these are the ones we always go on if we've got multiple abnormality to do whole exome sequencing. Now, we don't have the ability at the moment in the UK to do whole exome sequencing for isolated congenital heart disease, but the study suggests there's about an 11% chance of finding something. So I'm hoping to do that in the near future. So what about cardiomyopathy in the fetus? How early can you pick it up? And I have picked it up at 14 weeks gestation, but that's only because we've actually, this lady had previously had babies with cardiomyopathy, and we found compound heterozygotes in the commonest hypertrophic cardiomyopathy gene, MYH7. So these really rare cases, you can pick it up very early, and our fetal cardiologist, she seems quite able to pick it up with some clever technologies, which I'm afraid I don't really understand. But normally, they do not present until the third trimester. And they can be due to the late onset cardiomyopathy genes that we deal with all the time, and they can be severe mutations within those genes. There are those autosomal recessive genes, like in that previous case, the MYH7. Those metabolic and mitochondrial causes not presenting until later on the pregnancy when the fetus is bigger. And of course, there's the rhizopathies. And the rhizopathies are probably the commonest cause of hypertrophic cardiomyopathy that we see antenatally, and lots of different genes involved with the rhizopathies. Some are more likely to have hypertrophic cardiomyopathies than others. We know that Costello syndrome, which is the HRAS mutation, is one of the rhizopathies which has a high chance of a prenatal hypertrophic cardiomyopathy, as does KRAS and RAF1 as well. So there are certain ones that seem to have a higher risk of hypertrophic cardiomyopathy. And the interesting thing about hypertrophic cardiomyopathy and Noonan syndrome, it doesn't progress after 6 months of age. So if you can get them over the first 6 months, and there's now treatments, it's trametinib. We need to pick these up early because there is treatment now, but I'm not keen on giving it to the mothers, I have to say. So at the moment, there is trametinib is being considered as an underlying cause for treatment for the Noonan syndrome. So RIT1, here was a case that we saw presenting at 28 weeks gestation, and they'd had a completely normal first and trimester scan. We only found this as a routine scan. So it can present completely late with absolutely nothing in the first trimester. So we have certain cardiac diseases that are more associated with congenital heart disease, with AVSD, with syndromic causes, and these are the ones with AVSD, traleophallid, and co-optation. And Some are very rarely associated with anything else, and that would be transposition of the great arteries. Single valvular heart disease, except pulmonary stenosis, is rarely associated, as are the hyperplastic left and right heart syndromes. So I'm just going to briefly talk about long QT syndrome, which in the majority of cases is an autosomal dominant disorder, but there are recessive forms of long QT syndrome. And we're picking these up more and more now with fetal bradycardias. And we're finding fetal bradycardia at the 12-week scan. And now it's not a routine test to document the fetal heart at 12 weeks, but we're picking these up. The autosomal recessive ones really are very nasty diseases and they often have deafness. So we can see these presenting at the first trimester. We're now offering, if we see fetal bradycardia and we can find nothing else wrong with the heart, we do parental ECGs, because sometimes we find both the parents have long QT or one of them, and then we're going on to do invasive testing. And there are various genes that we found causing recessive long QT. Lastly, we've got CPVT, which is this catecholinergic polymorphic ventricular tachycardia. 30% risk of sudden death by 40. Not a nice condition. Again, well worth picking up. You miss it on every single test you do because you have to do an exercise test. These kids can drop down dead at 18 months. You can't do an exercise test on an 18-month-old. So, well worth picking up if you find a fetal bradycardia. So, what tests do we do? Congenital heart disease. Start with a QFPCR. We know the trisomy is a common cause. A microarray, and I would like to do a trio exome, but I'm not allowed to. So cardiomyopathies, we do trio exomes on them. Sometimes panel testing can be better because of the various nuances, but a trio exome is your best hope. And the bradyarrhythmias, probably a pediatric panel, is probably better for various reasons than an exome, but you could potentially do both. Right, that is a real rush through congenital heart disease, and I hope you managed to pick something up from it. Thank you very much.